Hello, everybody. I'm really excited to be back, and it feels so good to be able to do this again and to be talking with you all and continuing on our journey of learning dermatopathology. And I am so grateful to all the people who have showed us support on Instagram and continue to follow me. And I hope that I can live up to everybody's expectations. And again, just enjoy talking about cases. And again, any kind of a feedback would be appreciated. I also wanted to let you know that we will be posting the YouTube link for the YouTube link for Anand Dermpath, and on that YouTube website we have a number of videos which we are going to post, which again you can subscribe to and click on and learn about a whole bunch of dermatopathology cases. Again, I'm utterly grateful, but let's continue back with our studying of dermatopathology. So, where we left last time, we were talking about Gottron's papule, and today I'm going to be talking about a specific variant of lupus erythematosus called Tumid Lupus Erythematosus. So, Tumid Lupus Erythematosus is one of those entities which tends to present with a non-discrete clinical presentation, and often the clinicians don't think about it. I have seen varying kind of differential diagnosis. It presents as urticarial or a papular eruption. So very often the clinical diagnosis for Tumid lupus is not straightforward, and a lot of times these patients may remain undiagnosed for a long period of time. They typically don't present with the classic lesions of lupus as one you would see in discoid lupus or subacute cutaneous or systemic lupus. However, the histology of Tumid lupus is really classic. And what we see in over here is a superficial and deep dermal perivascular lymphocytic infiltrate with also perifollicular inflammation. And this kind of a lymphocytic infiltrate is pretty dense and described as with the tight perivascular cuffing pattern. So it's very distinct and something which is very recognizable as lupus when you see it on low power. So superficial and deep dermal perivascular and perifollicular lymphocytic infiltrate presenting with this kind of tight perivascular lymphocytic cuffing. So you can see how it nicely, encircles the blood vessels. And in the past, this kind of a tight lymphocytic infiltrate has been put in the category of lymphocytic vasculitis. And obviously, we do not want to use that terminology because it's confusing, it's misleading. There isn't any true vasculitis here. We don't see any fibrinoid necrosis of the vessel wall. It's just a tight lymphocytic infiltrate surrounding these vessels. Another finding in Tumid lupus, which is essential and completely important for its diagnosis, is the presence of interstitial dermal mucin deposition. So you can see that in between and among the collagen bundles, you can see this kind of a stringy mucinous basophilic material, which is all mucin. The mucin is pretty easily identifiable, but again, it's not something which is in your face mucin. So when you look at the biopsy, the biopsy is more diagnostic for its superficial deep perivascular lymphocytic and perifollicular inflammation. And really, on the second thought, you will go and check for mucin. So it's not something that the mucin hits you in your face most often. And it's a lymphocytic infiltrate which is more impressive. And then you go on high power and you confirm that, yes, there is interstitial mucin. Another thing which I want to really emphasize before you make a diagnosis of Tumid lupus is that the epidermis in Tumid lupus is completely unaffected. So you can see that the overlying epidermis shows no change at all. It's unaffected. It's completely normal. You do not see any interface change, and you should not see any interface change. If you see chronic interface change in the overlying epidermis, then you would rather put it in the category of more classic lupus rather than the Tumid variant of lupus erythematosus. And again, the DIF findings in most of the cases in for Tumid lupus is non-specific, non-diagnostic. So you shouldn't really rely on a DIF for making this diagnosis. It's more of a histologic diagnosis with this dense superficial deep perivascular perifollicular infiltrate and interstitial mucin. I'm going to share with you guys another slide just to emphasize that point. This is another case of Tumid lupus, and you can see here how nice the superficial and deep perivascular and perifollicular lymphocytic infiltrate there is. There is tight perivascular lymphocytic cuffing, and again, you can go up on high power look at the the nature of the infiltrate. It's a tight lymphocytic infiltrate, predominantly lymphocytic. You shouldn't be able to see any eosinophils scattered in the background, and again the overlying epidermis is completely unaffected. Now the mucin is extremely subtle, and you can go on high power and you can confirm the presence of mucin, but it can be pretty it's not like in your face. You'll be able to see it, but sometimes you can struggle, and you can get like special stains for mucin, like colloidal iron, to prove that there is mucin in the biopsy. But most often, I would have to say, in 99% of cases that I see, the mucin is easily seen as this basophilic stringy material kind of present in between and among the collagen bundles. And again, remember, no epidermal change. So tomorrow, I'll be talking about a whole category of diseases referred to as gyrate erythemas, which again present with this reaction pattern of superficial deep perivascular lymphocytic infiltrate with the tight cuffing. And we'll talk about their histologic similarities with tumid lupus and how to diagnose and clinically distinguish these varying gyrate erythemas. So we'll talk about that more tomorrow, and hopefully you guys enjoyed this little presentation, and I'm looking forward to interacting with you all again. Have a great day.